So as I just mentioned, my overarching goal at this point really is to improve the care of people who are diagnosed with FND. Functional neurological symptom disorder is the current technical term per our newest edition of the DSM, but most of us still refer to it as the acronym FND. And again, like I said, I think that hopefully by talking about this, we can begin to sort of spread some of the newer knowledge about our understanding of FND and the way that we're thinking about it and talking about it and approaching the treatment of it to help improve care. So what I plan to cover is a discussion of what is FND, who gets FND and why, and how we treat FND, and then talking a little bit about the development of our program here at Johns Hopkins. So regarding the first question of what is FND, generally speaking, what FND means when someone's diagnosed with FND is that they have some sort of altered sensory or motor function, and it's not explained by anything else, not explained by another diagnosis or problem. Currently, per the DSM-5 TR, our current edition of the DSM, those are our criteria, and then the current edition of the ICD-11, the criteria are a little bit different. The good news is that even in the international FND community, despite the fact that there are some differences in terms of terminologies and the actual criteria, I think we're all at a point now where we're working really well together with a shared collective understanding of FND, and we all tend to use the functional neurological disorder terminology. A couple of the things that I'll point out here about the actual diagnosis itself and the terminology is that you'll see that in the newest edition of the DSM, the term conversion disorder is maintained there in parentheses. And the reason that we've moved away from that is because the conversion disorder terminology implied the conversion disorder model, which is that there's some sort of a psychological cause of the person's symptoms. And well, that certainly fits in a lot of cases. An example of that, where there was this acute traumatic event and then the onset of these sensory and motor symptoms. What we've learned over time is that that's definitely not the case for all patients with FND. And so I would say my clinical experience and the recent studies looking into that suggest that up to maybe 50% of people who end up getting diagnosed with FND don't fit that sort of traditional historical conversion model where there's that major acute traumatic event or stressor that really seems to precipitate the symptoms. And so I think that is one of the biggest reasons why we've sort of moved away from the conversion disorder terminology. And I think sort of related to that, the reason why that's been unhelpful for a lot of patients to use the conversion disorder terminology is, again, because it doesn't fit. It doesn't make sense because that's not their experience. So explain how, this is sort of a stress reaction and it fits with this conversion disorder model, that might resonate and make a lot of sense and be very validating. But for other patients, again, maybe 50% of the patients we see with FND, that's just not the case. And so what that often does is if you explain it that way, that this is a stress reaction, particularly for somebody who's nearly alexithymic or frankly alexithymic, that just won't resonate. And they'll say, that makes no sense. I don't even experience emotion, period, let alone I don't feel stressed out. So that just can't be. And then what ends up happening there is that they really reject the diagnosis and they're resistant to treatment and they really don't get better. So the point here is that I think the terminology and the way that we talk about FND and the way we explain FND really does matter. And that's just one of the reasons why. One of the nice things about the new criteria in the DSM is that you can specify whether there is a stressor or there's not a stressor. So again, clarifying whether or not that particular case or that patient sort of meets that conversion disorder model. Looks like I maybe lost the mouse here. Okay. Oh, there it is. Now it's back. Okay. Another thing that you can do with the current criteria in the DSM is you can specify a subtype of FND, because FND really does present with many different sort of manifestations and presentations. And so you can specify whether it's a functional neurological disorder with attacks or seizures, so seizure-like episodes or sort of attacks, whether it's sort of a more persistent thing like a functional movement disorder, like a functional tremor, whether it's with speech symptoms, mixed symptoms. We see a lot of patients with mixed symptoms. other really sort of common manifestations of FND include triple PD, persistent postural perceptual dizziness, functional cognitive symptoms. We now actually have some working criteria for what's being called a functional cognitive disorder. Those things I'm not going to talk in detail about today, and I'm going to focus on the most common clinical manifestations, which really are sort of the functional seizure-like episodes or attack-like episodes that patients have, and then the more kind of persistent functional movement disorders, which most often it presents as a functional tremor, sometimes a functional gait disorder, weakness, paralysis, sometimes sort of stroke mimic symptoms like Miss Marks was experiencing. Those are really the most common subtypes. And fortunately, actually, those are the subtypes for which we actually have the best positive markers or rule-in signs. So technically, if you look at the criteria, they are still really diagnoses of exclusion, right? There's no requirement here for any of these patients to have positive rule-in signs, okay? So that's a question that often people ask is, isn't this just a diagnosis of exclusion? Isn't it just a wastebasket diagnosis? And the answer technically is, well, yeah, technically yes, according to these criteria, because again, you don't have to have positive rule-in signs in order to make the diagnosis of FND. Another thing that I'll point out, this is a question that people often ask about the voluntary or involuntary nature of FND and these symptoms. And there's actually inconsistencies even between the DSM and the ICD in terms of the use of the word voluntary and involuntary. But the important point is that FND implies that somebody is not willfully, knowingly faking their symptoms for the purpose of some gain, as would be the case in something like malingering or factitious disorder. But the truth is that what we think is probably going on in the brain is that there's kind of a mismatch in the brain in terms of the person's perception of their movements or lack of movements as being voluntary or involuntary, so that the person experiences them as being involuntary, but technically speaking, they're coming from a place of voluntary control, okay? And so that's why the therapy for FND really is about reprogramming and reshaping a person's sense of agency and their sense of control. In a very oversimplified explanation, that's sort of what we're doing, is trying to fix that mismatch, the confusion in the signals essentially in the person's brain that's telling them that I can't do this, I can't control this. We're helping them regain that sense of control in a sort of a reprogramming effort. The last thing I'll say about the diagnostic issues is that despite the fact that we have this inconsistency and variability still going on in terms of terminology and criteria, the misdiagnosis rate is very low. Studies have suggested that the misdiagnosis rate of FND is actually about 4%, and the misdiagnoses for other neurologic conditions, or people being diagnosed with other neurologic conditions when they actually have FND, is much higher. So, for example, studies suggest that up to 70% of patients who are diagnosed with epilepsy don't actually have epilepsy, and a large number of them actually end up having functional seizures. So again, that's another thing that commonly comes up is, is this misdiagnosed, or people just thrown into this wastebasket and they actually have something else going on? The answer is yes, that does happen, but it's rare. And actually the inverse, the opposite, is much more common, which is when patients are diagnosed with things like MS, stroke, epilepsy, Parkinson's disease, and they don't actually have those things. Instead, they have a functional neurological disorder. So a little bit about the positive or rule-in signs that I mentioned. So again, that's not part of the criteria right now. You don't have to have positive or rule-in signs, or a person doesn't have to have those in order to get the FND diagnosis. But they do exist, and they are used clinically, particularly in FND programs like the one that we're building here at Johns Hopkins. Our movement disorders neurologists rely heavily on the positive rule-in signs, and they pay very close attention to those, and they show those to their patients when they're examining them as a way of explaining what the diagnosis is and demonstrating that it is not simply a diagnosis of exclusion or a wastebasket diagnosis. So for functional movement disorders, the positive or rule-in signs are pretty well established, and I would say the three main ones that a provider should be looking out for are distractibility and suggestibility, and those are pretty obvious. So, if you engage somebody in an activity that's unrelated to their symptoms, what you might see is sort of remission or improvement in the symptoms. That's the distraction. the suggestibility is kind of the opposite. So if you talk to somebody about their symptoms, you're asking questions about their symptoms, you might see a flare-up in their symptoms. And then entrainability is the third feature, and that's a little bit less obvious, but basically what that means is if somebody comes in with a functional tremor and you have them rhythmically tap with their unaffected hand, what you might notice is that the tremulous hand starts to kind of adopt the same rhythm as the unaffected hand, and so that's entrainability. Variability is also a major marker for functional movement disorders that movement disorders neurologists look out for. So again, these features do exist, and they're very helpful in terms of making the diagnosis, and not just making the diagnosis, but again, explaining it to the patient and explaining, look, here's what's happening, here's why we think this is happening. There's a mismatch in your brain in terms of what you think you can do and what you can actually do, and we need to essentially reprogram that with physiotherapies and talk therapies in order to see improvement. The other subtypes, so again, I said I was going to be kind of focusing on the two main subtypes here, functional movement disorders and functional seizures. So functional seizures, the gold standard diagnostic procedure for that is continuous video EEG monitoring in an epilepsy monitoring unit like we have here. The ability to diagnose FND with shorter term EEG and also based off of video recordings or, epilepsy neurologists or other expert clinicians observing the episode, that's pretty good as well. So there's obviously a lot of places where people don't have access to EMUs, and so in those cases, short-term EEG and sometimes clinicians watching recordings of episodes or actually witnessing the episodes themselves can be really helpful in terms of making the diagnosis. And some of the positive or rule-in signs for functional seizures are eye closure, really long duration of episodes, so really anything more than a couple minutes, preserved awareness during convulsions, with or without the ability to communicate, and crying during or after events. Those are all typically positive signs for functional seizures. At the same time, we also know that features that we typically or historically associated with only epileptic seizures like tongue biting and incontinence, we thought that those could only happen if a person was having an epileptic seizure, and that's actually not true. We do see patients who have non-epileptic seizures and they have tongue biting and incontinence. So again, the semiological diagnosis or semiological features alone are imperfect, certainly. Okay, so I included this table because, again, I think it's a great resource to have basically outlining in the left-hand column what are some of sort of the commonly used positive or rule-in signs for functional movement disorders, and then later on functional seizures. And then on the right-hand side, in the right-hand column, there are sort of some newer positive rule-in signs or diagnostic tools and biomarkers that are being examined. So I'm not going to go through this line by line, but again, I included it just to point out that, as you can see, some of the features that I was talking about, the entrainment, variability, those are things that are pretty regularly looked at and looked for. And then there's some newer ones that are emerging as being really helpful. The whack-a-mole sign is one that our movement disorders colleagues have shown me many, many times as being a helpful positive rule and feature. And then this table, in case anyone's curious, came from a great paper that was written by Dr. Mark Hallett, who's been a real pioneer in this field. He was actually the person who really started our international society. This is a paper that he published a few years ago that does a nice overview of FND and some of the sort of current and more recent understanding of it. So as the table goes on, again, it's in the left-hand column. Those are the features I was talking about, variability, and then some of the newer things that we're starting to observe more and more of. The huffing and puffing sign, that's one that the movement disorders neurologists observe often and include as a positive sign. And then here, in the final part of the table here, the bottom part is about functional seizures, and you can see there they mention some of the positive rule-in signs that I mentioned: the eye closure, prolonged attacks, weeping, and some of the newer things that we're looking into to use as biomarkers. Okay, so moving on, I see the time is ticking. So who gets FND? So a little bit about the epidemiology. As you can see, FND has been documented across the lifespan from children to older people. Typically, functional movement disorders tend to emerge in the late 30s. Functional seizures tend to emerge in the late 20s on average. There's definitely a female preponderance. About 60 to 80% of patients with FND are female. That's narrower, that gender gap is narrower. There's actually a more equal distribution, gender distribution earlier and later in life. This is very common. It's the second most common new referral to neurology clinics, and 1 out of 6 outpatient neurology referrals are for FND. So it's quite common. The incidence rates and prevalence rates you can see there. I think very importantly, the levels of disability, caregiver burden, functional impairment and limitations, those things, those difficulties, quality of life, those are all at least as high and problematic as for folks with other conditions. So, and related to that, the healthcare costs are enormous, and a lot of those costs are on things that are ultimately not helpful, such as continued workups that don't need to be done, medications and surgeries for conditions the patients don't actually have, such as epilepsy and Parkinson's disease and MS. And the healthcare costs actually for FND are apparently growing at a higher rate than they are for other neurologic conditions. So as you can see, there's a real need here. Okay, so why do people get FND? What causes FND? So generally speaking, we understand FND as a problem with the functioning of the nervous system and sort of how the body and the brain are sending and receiving signals. So more of a connection problem than a structural disease problem. There have been numerous structural and functional neuroimaging studies that have been done over the years, but we're still way far away from coming up with any use of those clinically. I think what's important to know is that the studies that have been done imply that there's some sort of miscommunication or some sort of alteration in the connections between the parts of the brain that take in sensory information, send that to the emotion hub, the self-agency hub, and then the motor production hub. And again, our sort of leading hypothesis is that the problem really has to do with a person's sense of agency and their perception of, in the example of functional movement disorders, feeling as though they don't have control over that when they in fact do have control over that. And so that's a large part of what the therapy is oriented towards, is sort of reprogramming essentially so that the person is able to maintain control and agency over their body's functions essentially. I think another one of our leading hypotheses, and one of the things that I see over and over and over again, is certainly a dysfunctional ability to experience and express emotion. And I think that's another thing that historically we've really misunderstood about patients with FND, is that we assume that everybody with FND was highly neurotic, highly emotionally expressive, overly so. And that is, again, just not the case. What I see even more often, I would say at least half of the time, if not more often, are patients who are sort of the opposite. Again, almost alexithymic. They really don't experience much emotion, positive or negative, which again, I think is part of the problem, because a lot of the times when people deliver the FND diagnosis, they say, oh, you're just stressed out. You just need to reduce your stress. And that just doesn't fit, because that's just not, for that person, that's not what their experience is. But again, I think the point is that this has to do with the way that a person is kind of interpreting their experiences, and the way that they're experiencing and expressing emotion. And so the therapies are essentially oriented towards those issues. Being mindful of time here, I think that's probably all I will say about that. Okay, so this is sort of an illustration of what I just said, but basically trying to understand sort of the pathophysiology of FND, if you will. What you see in A is there's symptoms, constructs, and neural circuits. So then an example on B would be somebody with functional movement disorder, functional seizures. So essentially, there's this disconnect, and maybe some studies have suggested that the area responsible for this is the temporoparietal junction. And so there's something going on there that's causing the person to basically feel as though their movements are involuntary when they're in fact voluntary. And so what we do is we try to go in and we try to reprogram that so that changes, essentially. Again, these neuroimaging studies are, you know, we have a lot of work to be done. The samples are small, the methodology is inconsistent, but we have some leads in terms of sort of informing where the problem might lie. But it doesn't really change much right now in terms of our actual treatment of FND, and I'm going to get there in just a moment. So why do some people get FND and not others? That's, I think, another burning question. So this is a busy picture, but I think it can be helpful. Basically, what it's outlining here is, if you go number by number, number one are predisposing factors. So these are some of the things that are really common in people with FND. And you'll notice that there are genetic risk factors. So there have been some interesting genetic studies starting to identify gene markers for folks with FND. But basically what this is demonstrating is that there are things that might happen in a person's life. Some of those things can be things, you know, like abuse, like depression, like exposure to neurologic issues or healthcare problems more broadly. So, you know, she was doing billing for neurology. Her wife was recently diagnosed with MS. We see a lot of that, a lot of patients who have illness exposure or exposure to similar symptoms or illnesses. And then if you follow the numbers going to number two, precipitating factors, that's sort of that stressor that, you know, if a person fits the conversion disorder model, that's kind of where you're looking, is what precipitated the onset of the symptoms. So, and then number three, comorbidities. So those are kind of happening, you know, at the same time, related to the FND. And then perpetuating factors. So we think about FND with these three Ps: predisposing, precipitating, perpetuating. And the perpetuating factors, that's really where we come in, and we're basically trying to do what those neuroimaging studies are trying to do and say, where do we think the problem is? Why do we think this is continuing? And from there, how do we develop a treatment plan around that, right? Do we think it's that the person's really lost their sense of agency, and they're, you know, they're afraid that they're going to fall, and that's why they're not walking, is because they, you know, it's a fear issue and a sense of agency issue? Is it more of an issue with dysfunctional, again, emotional experience and expression? Is that what we need to work on, et cetera, et cetera? So in any case, that's sort of how we think about FND, is that there are things that might predispose a person to developing it, maybe or maybe not something that sort of set it off, and then certainly things that are causing it to perpetuate or continue. But really at this point, it's a very subjective exercise where someone such as myself is basically saying, here's what I think. Here's what I think is causing this, and based on what I think is causing this, here's what I think we should focus on in treatment. And that's sort of how it goes. In terms of some of the predisposing factors, I just want to spend maybe a minute on this. I think one thing that's important to highlight here, again, is just one of the historical understandings, is that everybody with FND has this dense history of trauma and abuse. That's not true. Of course, you know, trauma and abuse are very common in FND. Some studies suggesting up to 75% of people with FND, but other studies suggesting maybe half of people with FND don't have that, okay? So again, just keeping that in mind to not make that assumption. Let me move along here with time in mind. So how do we treat FND? What do we do once someone's diagnosed with FND? Well, the first thing that's really important is the diagnosis itself. And I think I've talked a bit about that, because it really lays a foundation for the person's understanding of what's going on and their ability to kind of get on board with treatment. And I think Ms. Mark. However, you know, that's important, the diagnosis itself, and it actually can sometimes lead to symptom remission temporarily. We'll often see people leave the EMU and we'll have given them the diagnosis, and then they won't have as many functional seizures afterwards. But that's usually short-lived, because then those other perpetuating factors kick in and it comes back. So that's not sufficient in and of itself. Same thing with psychoeducation, helpful but not sufficient for real improvement. Avoidance of iatrogenic harm, also important, but it's not going to result in major changes. The real sort of bread and butter in terms of treatment for FND is psychological interventions, or psychotherapy and physiotherapy. So those two types of therapies are really what are most helpful. In terms of psychological interventions, the most research has been done on CBT, but there's actually a lot of other different therapeutic frameworks and models and techniques that are used and are used successfully. So I'm actually working with an international group from our society to come up with some consensus recommendations for psychotherapies for FND, using the Delphi model, a Delphi model to approach that study. So hopefully that'll come out in the next few years with a little bit more guidance there. But I think the important part is that just saying that everybody with FND just needs CBT, period, is not doing justice to coming up with the kind of treatment plan that's really going to be most helpful for people with FND. There are some great manualized treatments, which I'll show a slide of in just a moment. So again, physiotherapies certainly have a role, oftentimes depending on the patient presentation. So for functional movement disorders, physiotherapies are incredibly helpful. For functional seizures, probably not so much. Oftentimes, if they're done together, the physiotherapy and the psychotherapy at the same time, people have the sort of best experience and best remission of symptoms. Other interventions, there's some newer interventions looking at brain stimulation, ketamine, psilocybin. I don't think we have time to get into that right now. I think another thing I'll say is that it's really important also to consider what are the goals for treatment when you're treating someone with FND. Is it symptom reduction? Is it improvement in quality of life? Is it reduction in depression and anxiety? What is the goal? And that's something that I think is really important to work collaboratively with the patient around. What is it that they're hoping to get out of treatment? Again, that definitely can sort of change and tailor the treatment approach. I think I've already said most of this. Again, just highlighting here that it's really important to consider a person's own experience and profile to figure out what kind of approach to treatment is going to be most helpful. The good news, as you'll see here, is that psychotherapy is very effective for people with FND. Sort of the number that I tend to cite is that on average, if people do sort of an empirically supported, kind of loosely based in the manualized approach, or at least FND-informed psychotherapy, on average, people get better by about 50% in terms of all of the things that I was just mentioning, remission of symptoms, et cetera, et cetera. Another thing that's important to consider that I don't think we have time to talk about today, but is factors that might indicate a better or worse prognosis for treatment and for recovery. So that certainly is a big issue. There's a lot of patients that you might see with FND who actually might have a really great prognosis and could probably easily benefit from some relatively simple interventions. But there's other patients that you'll see with FND where the prognosis is probably much more challenging. So that's another important thing to consider. This is the approach that I was trained in. It's a cognitive behavioral sort of framework, the person who authored this, one of the authors, Dr. LaFrance, he actually is in the process of publishing the same sort of approach for FND more broadly, because this was about really functional seizures. I've actually been using this as a framework for treating FND more broadly for years myself, and it works very well. So this is, importantly though, this is an approach that has to be done with a therapist who's trained in this, sort of working alongside the patient. This book is also an excellent book, but it's more sort of a self-help book for patients with FND. Okay, the last thing I'd like to do, if I can just take one quick minute here, is just talk a little bit about what we're doing at Johns Hopkins. So we have, I hope this opens up. I don't think it's going to. Okay. All right, well, that's not going to open. So that's our website. So we have a website that we're in the process of launching. And essentially what the website does is it really informs providers, patients, caregivers, family members about all the different resources at Johns Hopkins for patients with FND. So we have some programs that have been around for forever, such as Dr. Treisman's incredible Meyer-6 service. And so we have a link for that, or to that, just because that program has been incredibly helpful for some patients where FND is part of the problem. And then we highlight some of our newer services. So I'll say that probably the most important there are the multidisciplinary approaches that we're taking to evaluating and treating FND. So we have two main mechanisms for that right now. One is a functional movement disorder clinic, and that's staffed by myself or another neuropsychologist, my partner, Dr. Eva Keatley, and then one of our movement disorders neurologists, namely Dr. Jason Chua. And then I have a similar program that I've implemented with the epilepsy neurology group, where I go up to the epilepsy monitoring unit on Fridays, and I'm basically there when the diagnosis is made for the functional seizures, and I sort of develop a treatment plan for the patients there, then and there, and then kind of follow along with them. So we've come a long way, I think, in terms of our ability to help patients here at Johns Hopkins with the implementation of these multidisciplinary programs. We've seen a lot of success. We're collecting some outcome data. I think one of the most exciting things that we've seen is in terms of what's called the BIPQ, the brief illness perception questionnaire. And basically what we've seen there is that patients that come to our functional movement disorders clinic, when they first come in, they really feel like they don't understand their FND, they have no control over it, they have no hope that they'll get better. And after they meet with Dr. Chua and myself or Dr. Keatley, they feel like they understand their FND much better, they feel like they have a much better chance of controlling it, and they're much more hopeful about treatment. So again, I think that the work that we're doing and the multidisciplinary approach is definitely the way to go. And I just want to take one more moment just to thank the people who've really helped me get to this point. Dr. Shretlin was amazing when I was a fellow, helping me be able to sort of begin to build this program and then join the faculty so that I could do this, and thanks to Dr. Potash as well for that. And then more generally to the FND community, the international community, Dr. Mark Hallett, David Perez, have all been incredible mentors and very welcoming, and it's been a great pleasure so far to do this work. And thank you all so much for being here and listening.
Thank you, Dr. Buchholz. That was extremely interesting. I'm really surprised that FND is the second most common reason people see neurologists. That is striking. Of course, it reminds me of all the visits to primary care doctors and other OBGYN doctors, to lots of doctors where a substantial portion of visits have psychological or psychiatric sort of origins. One question I have for you is, any sense of what proportion of the people who see neurologists for FND have diagnosable depression and or get treated with antidepressants?
Yeah, I think it really depends probably on the subtype. It seems that psychiatric comorbidities are actually more common in patients who have the functional seizure subtype than in patients that have the functional movement disorder subtype. So it depends on the study, but I would say, at least 50 to 75% of patients with functional seizures have some sort of psychiatric comorbidity, with depression being really common.
Okay. Dr. Tobolowsky.
Yeah, great question, Will. I've seen it. I would say in the past, 7 or 8 years here doing this, I've only seen it maybe a handful of times. So it happens, but not super commonly.
Interesting. Dr. Taylor.
Thanks, Jake. Yeah. So it's pretty stable. We don't really know what to make of it. Again, it's interesting that there are differences in terms of the emergence of FND, when that tends to occur based on the different subtypes and maybe also based on gender. So we really don't know, but I think one point that someone made recently to me when I was having this conversation is that we also see gender differences in other neurologic conditions like MS, for example, right? So I don't think we know. I think historically the belief has really been that it has to do with abuse and trauma and assault and sexual assault, and that girls and women were more likely to have endured that than men. And that certainly could be part of it as well. We just don't really know.
Certainly somewhat reminiscent of the gender difference in depression and anxiety as well. Yeah. Other folks? Dr. DePaula.
Yes, I want to say first off that I don't disagree at all with the formulation and the treatment. I'm very concerned about creating new names, new titles for disorders.
Yeah.
Because you can do a race history. You can do a positive diagnosis, what you're really trying to say first off, in this case, there's something you don't have. But the second part you're saying, obviously, good. We can help.
Mm-hmm.
The definition of hysteria in the past included a more or less conscious, more or less voluntary simulation of disorder. That's an explanatory diagnosis. Functional neurological disorder doesn't explain anything by itself. Okay? So we've done this in DSM. This is Dr. Howard's a good neurologist, but I think he's outdone DSM. In my group, we created disruptive dysregulated mood disorder in children because we didn't want to profile them. Okay? That really is the end of the day, all that helpful. So why do we erase the history and start covering other people that actually do something about this?
I think that's a great question, Dr. DePaula. Thank you for asking it. I think probably one of the biggest reasons is that for a lot of these patients, they don't sort of fit the traditional conversion model. There's not an obvious psychological stressor.
Not required for conversion in my opinion.
Okay.
Anybody else? We have one more. Yeah, go ahead.
Oh, great question. Yeah, there's actually been some really good studies on that. So it's interesting, this sort of adherence was measured in a couple studies by people attending, I think, 8 out of 12 of their sessions, and that seemed to be enough. That was good enough. So really not a tremendous amount. Great question.
Well, with that, we will wrap up. Thank you very much. Fascinating round.
Thank you. Thank you.